Assalamu alaikum. First of all, I'd like to express my apology for the delay happened for this session. We were supposed to start 30 minutes earlier, so without further ado, let me just introduce Dr. Mubarak Aldossari to present very late stent thrombosis live in a box case. Dr. Mubarak Aldossari is a consultant interventional cardiologist and the head of cardiac center at King Saud Medical City in Riyadh. Dr. Mubarak Aldossari is a close friend of mine, and I would like to praise him for moving his center from low-scale center to the highest primary BCI center in the kingdom. Dr. Mubarak, go ahead, please.
Assalamu alaikum. Thank you, Dr. Ali, for this introduction, and thank you for organizing committee for this opportunity to present one of our cases in cath lab at KSMC, King Saud Medical City, Riyadh. We can start the
Riyadh. I would like to welcome you for this live unbox case from our cath lab. At the beginning, allow me to introduce our fantastic team. With me, Dr. Hamad, the cath lab fellow, interventional fellow, and Abdullah Mtair is scrub nurse. Abdurrahman Malki is our senior radiographer, and our CPT is Soshan, and our circulator nurse and documentary nurse Muhammad Sufyani and Berlin. And we have also Dr. Hatim Al-Alawi, interventionist. He's going to comment on the imaging modality during this case. Please, Dr. Hamad, can you present our case?
This gentleman is a 54-year-old gentleman who came to us through the emergency, in our emergency with foot for 2 hours. He is non-diabetic, hypertensive, and has ischemic heart disease for the last 15 years. 15 years ago, he had PCI done to LED in 2006 or 7. We don't know exact dates. And one stent was deployed in the LED. We also don't know the type because the patient doesn't remember the name, and he also does not have a report. So we took him to our cath lab with chest pain as primary PCI due to anterior wall amputation. He showed acute ST segment elevation in all the chest leads, V1 through V6, L1 and AVL, with reciprocal changes in the inferior leads. So after that, we took him to the cath lab and we shot.
Dr. Mubarak, may you go ahead and just comment on the.
This patient, he came as anterior wall MI with all the stent history with 12 to 15 years ago, and he was taken as a primary with anterior wall MI to the cath lab. The first operator who did the angiogram, we can appreciate in this views that there is stent thrombosis from the proximal of the stent. And he opened the culprit vessel, which is the LED, with ballooning, as you could appreciate in the angio, with the good distal flow of the vessel. There is still moderate to moderately severe lesion in the mid to distal stent. Now, just we can just do the voice.
Back to the voice, please.
Back to the voice, Billah.
Our colleague interventionist who did the procedure is nicely opened the LED as you saw in the image. So he decided to do imaging for this stent to ascertain what could be the cause of this stent thromboid
done during
previous procedure.
run from the LED to the left main done during the index procedure, and it's a co-registration. As you can see distally, the LED is quite healthy, and we start having a mild plaque here at 7 o'clock, and we have some characteristics, as you see here, of an unstable plaque with some macrophages infiltrates there. And going toward the stent, we start seeing that plaque which is dissected, and most probably this plaque was dissected during the inflation of the balloon distal to the stent. Inside the stent, which starts from here, we see the material, it looks a heterogeneous material inside the stent with some adipotic tissue here, with of course a dissection of that tissue. And being heterogeneous like that, most probably, since we have, as you'll see, we have a thick fibroadipotic plaque inside the stent with some calcium, deep calcium nodules, it is most probably a new atheroma inside the stent that get ruptured and explained the very late instant thrombosis. So this is the stent all the way along the proximal part of it. We see some thrombus overlying the plaque. We see some deep calcium around the stent itself. Here we have a deep calcium around the stent. Up to this part. So the stent stops at this part. And if we measure the length of the stent, we don't have any idea about this type of stent, but at least we know that it's a 33 stent in terms of length that is opened to a diameter of almost 3 millimeters. This is the proximal part, but if we go inside the stent here, for example, we'll have a deployment of a stent of almost 3 millimeters of deployment. So the stent stops at this portion. We have a plaque proximal to the stent with some deep calcium. It's a fibroadipotic plaque that I recall it has been ballooned, and you see a dissection of this plaque up at the osteoproximal part of the LAD. So the ostium of the LAD is dissected at a level of a fibroadipotic plaque, and the previous stent lands at almost 14 to 15 millimeters from the ostium of the LAD. Of course, we don't see clearly the left main. We just see the distal part of it with the adipotic plaque here, fibrotic plaque. So it's a plaque that actually starts from the left main and protrudes inside the LAD. So we know a little bit about the mechanism. Most probably it's a new atheroma inside the stent that gets ruptured, but we need to have more information. We don't know exactly what we are dealing with. This stent, what is it exactly? The capability of overexpansion of this stent. The artery itself, what's the reference diameter? You have seen that we can't see the deep part of the artery, and that's the limitation actually of the OCT. So the interventionist decided to know more about this artery, to know how much we have to expand the stent, and if this stent is really undersized compared to the vessel or no. So he decided to move to another modality and to do a NIVUS to understand more about the artery itself. So this is the IVUS done during the same procedure. This is the stent, as you can see, which is opened at 3 millimeters, 3.1, 3.1, quite circular. As you see, we can't see with precision that dissection that we have seen, of course, by OCT, but our interest here is the vessel itself. How large is this vessel, and if there is any undersizing of the stent compared to the vessel. As you can see here, the vessel itself, if we go media to media, is almost 4.5 millimeters. So the stent is quite small compared to the vessel itself. Media to media, this vessel is a 4.4, 4.3. So we have probably an undersized stent. We don't know. This is a positive remodeling, so it's quite difficult to know if this positive remodeling was existent during the first procedure or it's a late positive remodeling. But the present states is that we have a small stent of 3.0 within an artery which is 4.5, 4.4 reference diameter, and with a stent that could not be deployed as you have seen in the angio with a 2.75 and the 3.0 a 3 NC balloon at a high pressure. The balloon could not open this stent.
Thank you, Dr. Hatem. After that, we take the operator took the patient out of the table. Next day, the echo have been done for the patient. As you are seeing in the echo, there is a clear severe hypokinetic in the anterior wall. The distal apex almost akinetic, and the ejection fraction is around 25 to 30. The patient have been referred to the cardiac surgery, but he was being declined because of.
Just at this point, Dr. Ali, it's an open discussion regarding the approach. We defer this patient to refer him for cardiac surgery as he's having stent failure, and he has an proximal ostial LED lesion, and to discuss him with the surgeon. Also, we defer him to start him on GB, 2B, 3A inhibitors, and to see what's the strategy is going to be done if we decide to take him later on. So we discussed him in our combined meeting, and the patient have been deferred or declined by the surgeon due to his low ejection fraction, and they thought he was not a good candidate for surgery, for surgical intervention.
Mubarak, sorry, was this acute ST elevation MI presentation?
Yes. This is an open, just we hear from others what's the approach from their side. We did it like this. We opened his vessel. He was quite stable pre-procedure, and TIMI3 flow on the LED.
I would probably go ahead with angioplasty based on what we have seen on the OCT. It's clear that there is new atherosclerosis and rupture plaque, though there is by IVUS you have demonstrated under expanded stent, but I think the etiology based on what we have seen in the OCT was new atherosclerosis and rupture plaque. So going ahead with complete angioplasty at that stage probably is reasonable. I don't know if any of the audience has different view, or just continue with what you have.
Severe LV dysfunction.
This was our discussion when we brought him again as an interventional team in the second session. About our strategy, BCI to LED, starting from the ostium versus crossover to the left main, and how we could overcome the old stent. We know the old stent size by IFAS, and it was, or OCT, it was a 3 by 33 mostly, but it's more than 12 years or 15 years old stent. How could we or how much size of the stent? Especially we saw the LED, it was around 4.5 in the proximal bar. And if we cross over, what's the techniques that we are going to do, whether professional or double stenting techniques, and even the modality or image guidance. Does this patient need MCS? His ejection fraction is a bit lower side. And as you see in his previous or diagnostic angio, he was having a CTO, RCA. What's the management plan of our RCA? I complete the...
Continue, please.
Yeah. Just we'll go through our records.
We took the patient again to the cath lab, and you can see his angio during the second procedure. As you appreciating, it's almost the same image that have been done the previous angio. the left main mild plaque in the distal left main. The lady looks diseased from the ostium. And the circ, as mentioned earlier, it's having osteal disease, and there is a principal OM which has moderate plaque in the mid segment, and the circ in proper circ is having osteal lesion after bifurcation. Cranial, please. This is the cranial. We can appreciate there is a significant lesion in the distal stent, the good, excellent caliber, and the lady distally there is still moderate ISR and inside the stent, and there is some retrograde filling to the RCA. Now we'll show you what have been done from our side. We choose EBU 35 as we might need some supportive catheter during the bailout if we need that. Now we wire the LED with the run-through wire. Then we pre-dilate again with a bigger balloon than previous balloon. It's a 3.5-15 balloon, inflated up to 24. You could appreciate the proximal part of the balloon where there is some step down of the balloon and the slipped down. So, but slowly inflation with the tension backward, it support to stay the balloon in the position, and it was showing good inflation in the balloon. Next, you could appreciate here there is some dissection in the proximal ostial LED, but the distal LED runs nicely, and the ISR in the stent is much better. The hemodynamics, I forgot to mention it at the beginning. The hemodynamics of the patient was fine. His blood pressure was 113/61, and his heart rate around 60. We decided to just go without any MCS support, as the patient is quite stable, even though we have to stand by in our cath lab. Now we'll go and do our IFAS. We'll show you the result of our IFAS. Dr. Hatem kindly will comment on IFAS imaging.
So this is the IVUS done after the post-dilatation. And we have chosen actually to do an IVUS instead of OCT for some reasons. The OCT has been done initially to know the mechanism or the etiology of the in-stent restenosis. Now we need to know more about the expansion of our stent, to control it more, and we judged that we can probably do it by IVUS in a better way than to do it with the OCT. And at the end we will end by doing most probably left main stenting toward the LAD. So to better see our stent position, our stent deployment in the left main, it's easier to be done by IVUS than to be done by OCT. Of course, by OCT we can do it, but we'll need some specific guideliner or guidezilla or guide extension to see clearly the position and the deployment of the stent at the ostium of the left main. So we decided to do the IVUS, and this is the run. So the LAD distally is fine, distal to the stent. We will have a small dissection, as you see here, just at the distal edge of the stent. But what is good is that the stent has been well expanded with our balloon, with the NC balloon at 3.7 expansion, homogeneous expansion, quite circular, and it's all the way along the stent length. We have probably, this is the smallest diameter we have. It's a 3.6 over 3.8. So we think that the stent is well expanded, well deployed now. Our plan actually was to go with super high pressure balloons, OPN balloons, in case the stent doesn't expand, since it's a stent implanted long time ago. But as we see, just with very high pressure, with quite high pressure, 24, with regular NC balloon, the stent has been able to be opened well. So we think that this result is quite satisfactory, and we can proceed with the implantation of the stent, of the drug-eluting stent.
Thank you, Dr. Hatem. I think now we will go, as the IFAS shows that the stent will open and will go to cover this stent with another new stent. We choose Onyx 3538 stent. The aim to cover over the previous stent, which was shown by OCT, is 3 by 33 mostly, and we'll cover the distal dissection, and we'll try to avoid the overlap segment with the previous metals and the new overlap. We decide just to go a few millimeters below the previous stent to cover the dissection. We can be guided by stent boost, small buffer. I'm going to wire the circ just to protect it in case if there is any effect with the circ or black shift. As you see, we took the Onyx system, and we use another wire for aorta to protect the proximal strut of the stent. As you are seeing, we use EBU, which can traumatize the proximal stent. Can we test it? Looks okay here. What do you think, Dr. Hatem? We can go here. Okay. Okay. Can you go and inflate Wahab?
Okay, stand up. Terminal 12, 12,
14.
14.
Alhamdulillah, it looks well inflated. Give me gentle pop on it. Okay, looks fine. 14. The wire is very nice. It protects me also while I'm pulling back the balloon. Okay, now we are going to do a bot with the 5015 NC balloon. Can I do boost with contrast, Wali? Okay. Ready? Inject. Okay, I think we can go and inflate here.
Balloon up. 12,
14,
14,
16,
16,
18.
18.
Okay. Lower safe. Down. Now we'll post dilate the proximal the distal stent with the 375 15 NC balloon.
Balloon up.
20,
20,
24.
24.
Okay, it looks nicely inflated. Down.
Down 24.
Inflate again.
Up again. 24.
Inflate again.
Up again. 24.
Okay, it's well inflated. As you see, the balloon doesn't seem homogeneous, so I will pull it a bit and I will inflate again. Go and inflate it down.
Down 26.
We can assess that by IFAS. We'll do IFAS now. Yeah, now we did IFAS. Dr. Hatem, if you kindly comment on the IFAS.
So this is the IVUS after the stenting, and we see the distal edge of the stent landing at a healthy zone. There is some spasm here, but the stent is positioned at a good landing zone distally. It's well opened at a 3.6 homogeneous deployment, good sizing, covering the whole stent quite homogeneously deployed, well opened here. Here we reach the left main, so the stent is deployed at 4.5, at 4.0. There is a symmetric deployment of the stent because there is some calcium here, as you see, preventing from homogeneous deployment. The left main itself is oval shape, making the deployment also in the oval shape. The positioning at the ostium is perfect. It's exactly landing at the ostium, covering the ostium, no protrusion into the aorta.
We can appreciate now that the ostial circuit finished. I don't know who's going pilot 50 the distal struts. I will try to open the distals, the LED. Fail, electronic balloon.
Balloon
Up to 8.
Balloon up. 8.
With the balloon because there is some sterilization with the 5O NC balloon. Silly. I think it looks nice. I think it's fine.
18.
20,
20.
22, 24.
24.
Okay. Go safe down. We'll do now the final eye first just to make sure our
So this is the ostium. You see here the circumflex. We see it much better than in the previous run.
I think
It's been opened with ballooning and with the kissing. And here is the left main, some eccentricity in the deployment of the.
I think we recross again to, because of short of time, we recross again to the circ. We did kissing and drug-eluting balloon to the ostial circ with the 275, and we reboot again, and the IFAS was showing good deployment of the proximal for the left main stent and the proximal LED.
Will you be able to show us the last angiogram?
Left main stent because of that calcium at the carina.
So,
but it is well opened.
yeah. So let me summarize the case, if you don't mind, Dr. Mubarak. I think this is a nice demonstration for very rare but catastrophic complication of drug-eluting stent having very late stent thrombosis, as in this case. Lots of messages out of this case, utilization of cardiac imaging in the cath lab, how to handle left main stenting and dealing with bifurcation with the circ. Again, I'd like to put more emphasis on the role of imaging to understand the mechanism of very late stent thrombosis, because knowing the mechanism will guide and direct your therapy in the cath lab and your strategy post-procedure. As you know, very late stent thrombosis could be patient-related, could be lesion-related, or device, or the previous procedure. Anyway, the final result was excellent, so we will have probably time to have one or two comments or question on this case after having your comment, Dr. Mubarak, on this case.
Yeah. As you said, Dr. Ali, and it's using the modalities. Imaging modality is very important to know the etiology of this stent failure, and we can have some debate regarding the approach of deferring this patient or doing ad hoc BCI in the same spot, even though our strategy is just like those patients. We take them out of the table. If they are stable, try to discuss them with the surgeon and with other colleague. Other strategies of this patient, I think it's very common and used in other cath lab. I don't have further comments rather than multidisciplinary teams, very important such patient.
Dr. Mustafa Shmimi, please.
Very well done, Dr. Mubarak. MashaAllah, you have a higher volume of primary BCI and you have dealt with the stent thrombosis very well. I think the message here as well that you have not need any support despite the ejection fraction 25%, and you are doing the left main, which is left main unprotected. The right coronary is not great. So this is another thing that you might still get away without any circulatory support. My question was that if you use the FFR or IFR, you might, with the reduction of the muscular amount of the myocardium, then whatever left behind might be enough to supply the remaining myocardium, and you might not need to go through all of this hassle, except that you might, properly made all the stent good, and you might do a small stent either for proximal. The distal, the distal dissection does not require anything. Any comment about using FFR for the muscle loss of the myocardium?
Well, I think using hemodynamics assessment or IFR during the ACS is still not well established, and I think it will mislead you treating such patient. Even though this patient have anatomical issues regarding the plaque characteristics and the atheroma more than flow disturbance itself. So depending on pressure wire and such ACS patient, I think it's not the practical way to treat such lesion. Imaging, maybe it's better to understand the underlying etiology of such case, and maybe after 1 week or 2 weeks, if you want to do pressure wire, that will be more suitable. Like during acute ACS, I wouldn't recommend from my side to do it for culprit vessel.
Final question, please.
Thank you very much, Dr. Mubarak. I think your patient was very lucky to get this exemplary management of the case. I have two short questions. The first one about antiplatelets. Was this patient during the 12 years on DAPT, or had they actually stopped the treatment? Because I can probably assume that this was a first-generation DAS, especially from the length, and it would be interesting to know. And that would further, would you keep them on lifelong DAPT or just 1 year? And my second question is about the RCA, and it's to you and to everybody in the room. Because, this patient is probably going to be asymptomatic regarding angina. He might have some dyspnea or some symptoms of heart failure. And we know recanalizing the RCA will not improve the LV function. But however, this patient's RCA, or his entire circulation, is now receiving the blood from a stented segment in the LAD. And we've seen that this had occluded before. So is an elective CTO RCA, when this patient is better, even though he might be asymptomatic, indicated to maintain the patency of the coronary tree in view of the fact that the largest artery, the left main, is now stented? Or should we leave it as it is and just hope that the stent,
I think he was on single antiplatelet when he presented to our emergency. I would recommend to be lifelong DAPT if he's low risk to have bleeding. Even we optimize our stent with imaging, and we are quite sure, technical wise, it's fine. Even we could call him as a good responder for stent, as he's survived within 15 years with the stent. Our strategy regarding RCA, we always discharge those patients. We bring them later on when we demonstrate any ischemia in his occluded territory, and we bring them as a day case later on within 1 month or 6 weeks if there is any demonstration for the RCA ischemia, to try to open this RCA.
My point is without ischemia, because I think there is a rationale for arguing that this patient might need their RCA as a sort of airbag, safety belt, without even demonstrating ischemia because of the poor LV function. So would you open the CTO if this patient...
No, if there is no demonstration, I'm not going to open.
Okay, thank you.
Okay, I'll take final question. Dr. Mohammed Kurdi, please.
Mubarak, I'm here to defend the stent, because I think the stent here is done very well for 12 to 15 years, and it's an innocent bystander that actually was taken in action because it is just there. It's a new endomal graft. The stent overperformed any 7S vein graft by being 15 years doing very well. The IVUS and the OCT showed well-deployed stent. There is a proximal rupture of a plaque, which is at the ostium of the LAD. And I totally think this is all a natural progression of the disease, and the stent actually did very well. So I congratulate whoever did the stenting before, and I'm defending the stent as well.
Thank you. At the end, I'd like to thank you again, Dr. Mubarak Aldossari, for this nice educational case, and thank the audience for your attendance and listening. Thank you.